Hello, and welcome back to Healing Hands Nursing. In this video, we're starting a new series focused on the Orthopaedic Nurse Certification Exam, Clinical Reasoning. This first video will cover degenerative disorders, the largest section of the exam. Before we move into the clinical cases, we'll briefly review the key concepts you need to recognize, not memorize, including osteoarthritis, rheumatoid arthritis, degenerative spine conditions, joint replacement, chronic pain, postoperative expectations, and rehabilitation priorities. The goal of this series is not to give you quick answers, but to help you think the way the exam expects you to think, using real-world clinical reasoning. Let's get started. Osteoarthritis is a degenerative, non-inflammatory joint disease caused by progressive cartilage breakdown over time. It's a condition driven by mechanical wear and tear. Pain typically worsens with activity and improves with rest, and morning stiffness is present but usually lasts less than 30 minutes. Laboratory studies are usually normal, which helps distinguish osteoarthritis from inflammatory conditions like rheumatoid arthritis. Osteoarthritis most commonly affects weight-bearing joints such as the knees and hips, as well as the small joints of the fingers. Patients often report joint pain, stiffness, decreased flexibility, and, over time, the development of bone spurs. On imaging, findings include asymmetric joint space narrowing, subchondral sclerosis, and possible osteophyte formation. In osteoarthritis, movement is part of the treatment, not the problem. Rheumatoid arthritis is a chronic, systemic, inflammatory autoimmune disease that primarily affects the synovial lining of joints. Unlike osteoarthritis, rheumatoid arthritis is not a degenerative condition. It is driven by inflammation and typically affects joints in a symmetric pattern. One of the key features is prolonged morning stiffness, usually lasting longer than 1 hour, which gradually improves with movement. Laboratory findings often show elevated inflammatory markers, such as ESR and CRP, which help differentiate rheumatoid arthritis from non-inflammatory joint disorders. In the early stages, patients may experience systemic symptoms, including fever, generalized malaise, fatigue, and weakness, along with symmetric pain and inflammation in the hands or feet. As the disease progresses, both the number and size of affected joints typically increase. Over time, chronic synovial inflammation leads to ponnus formation, which begins to destroy surrounding cartilage, tendons, and bone, resulting in erosions and joint deformities. If inflammatory markers are elevated and stiffness lasts longer than an hour, stop thinking osteoarthritis, think rheumatoid arthritis. Degenerative disc disease is an age-related condition in which the intervertebral discs gradually lose hydration and elasticity, reducing their ability to absorb shock. As the discs dehydrate, they lose height and become thinner and weaker, placing increased stress on the surrounding spinal structures. Over time, this added stress may lead to bone spur formation and contribute to narrowing around nerve roots. Patients typically experience chronic, mechanical neck or back pain that worsens with activity or with prolonged sitting or standing. In some cases, disc degeneration can result in nerve root compression, leading to radicular symptoms such as pain, numbness, or tingling. Laboratory values are usually normal, which helps distinguish degenerative disc disease from inflammatory spinal conditions. Management is conservative first and focuses on physical therapy, core strengthening, posture and body mechanics education, and pain control. Degenerative disc disease is disc wear and tear, not inflammation. Spinal stenosis occurs when age-related degenerative changes narrow the spinal canal, leading to compression of neural structures. Patients typically report pain that worsens with extension and walking, and improves with flexion, a classic finding known as the shopping cart sign. Symptoms are usually chronic and progressive rather than sudden or acute. As the spinal canal narrows, nerve roots or even the spinal cord may become compressed, contributing to neurologic symptoms. It's important to remember that neurologic recovery after surgical decompression is gradual, not immediate. Common degenerative causes include abnormal bone growth, such as osteophyte formation, thickening of spinal ligaments, particularly the ligamentum flavum, and bulging or herniated intervertebral discs. Spinal stenosis is a structural narrowing problem, not an inflammatory process. Total joint arthroplasty, including total knee and total hip replacement, is performed to restore function and improve quality of life. However, successful recovery depends heavily on nursing priorities and patient education. Infection prevention begins before the incision is ever made, not after surgery. Adequate pain control is essential, not for comfort alone, but to allow the patient to safely participate in mobility and rehabilitation. Early ambulation plays a critical role in reducing postoperative complications, including thromboembolism, pneumonia, and functional decline. For hip arthroplasty patients, precautions vary depending on the surgical approach, such as posterior versus anterior, and must be reinforced consistently. Functional recovery follows a clear progression, from pain control, to mobility, and ultimately to independence. Pain control is not the goal. Mobility is the goal. The ONC exam frequently tests your ability to distinguish expected postoperative findings from true complications. After orthopedic surgery, some findings are normal and expected as part of the healing process. These expected findings may include pain with activity, mild swelling or warmth around the surgical site, and transient numbness as nerves recover. However, certain findings should immediately raise concern for a postoperative complication. Red flags include fever accompanied by purulent drainage, new or worsening neurologic deficits, and any bowel or bladder dysfunction. Expected does not mean ignored, but it does not always mean emergency. Degenerative conditions require long-term management strategies, not quick fixes. Effective pain control for degenerative disorders relies on a multimodal approach that addresses function as well as comfort. Exercise and strengthening play a central role in managing chronic degenerative pain and maintaining mobility over time. Opioids are not considered first-line therapy for long-term management due to limited benefit and significant risk. Surgical intervention is typically reserved as a last resort when conservative measures fail. Degenerative pain improves with motion, not rest. While most degenerative spine symptoms are chronic and progressive, certain findings require immediate action. New-onset urinary retention, bowel or bladder incontinence, and saddle numbness should always be treated as medical emergencies. These symptoms suggest possible cauda equina syndrome and require urgent evaluation and intervention. Bowel or bladder changes in spine patients are always an emergency. If you're preparing for the Orthopedic Nurse Certification exam, remember this: success doesn't come from memorizing facts, but from understanding patterns and applying clinical reasoning. Degenerative conditions follow predictable pathways. When you recognize those patterns, the questions become clearer and the answers more logical. In the next videos of this series, we'll continue working through high-yield clinical scenarios designed to help you think the way the exam expects you to think. Thank you for learning with Healing Hands Nursing. If this video was helpful, don't forget to like, subscribe, and turn on notifications for more nursing education focused on safe, evidence-based care.